Good afternoon, ladies and gentlemen. It's my pleasure to introduce you to today's lunch symposium. Though induction immunosuppression has been there since the beginning of the transplantation, and anti-thymocyte globulin has been available for more than 3 decades, we have been still learning about it, how to optimally use it, and what's the best use in our situation, especially living donor transplant. To deliberate on this topic, we have with us today Professor Stephen Tullius. He is the Professor of Surgery at the Brigham and Women's Hospital at Harvard Medical School. He'll give the talk about the use of induction immunosuppression in living donor transplants, and then we'll have some discussion with my colleagues on the dais. Professor Tullius, please.
Thank you very much. Thank you very much for the introduction, and welcome to the session. A pleasure for me to talk to you about the induction immunosuppression in general, but particularly as it is relevant for living donors, as this is a large portion of transplants being done in these countries. Those are my disclaimers. I want to start out by an overview on how we design immunosuppression. You see here a way that this is designed in a very superficial way on how different immunosuppressants operate and work. They all target different aspects of the immune system. They all are by themselves not sufficient to target the immune system in an allospecific way. Yet what we have achieved is an immunosuppression that results into a very successful long-term graft outcome, and the goal is to reduce the amount of acute rejections. What you see here are also the most relevant immunosuppressants that we are going to talk about, ATG and basiliximab, 2 agents that are predominantly used for induction treatment. And the induction treatment has a few purposes, which I'm going to refer to in 1 second. The history of the use of induction treatment has started with organ transplantation. Pretty much it was the goal to prevent acute rejections and to facilitate the minimization of maintenance immunosuppression. And the lymphocytes were first demonstrated in their effectiveness already in the 1960s, and that's when chemical immunosuppression started. Those were frequently at the time homegrown institutional products that were produced as anti-lymphocyte serums, and then becoming available initially as the host antithymocyte globulin, then later on followed by the rapid antithymocyte globulin in the US in Europe in '84, and then in the US in 1990. And then later on the development of an interleukin-2 receptor antibody specifically targeting the target on activated T cell, the interleukin-2 receptor that is critical for the initiation of the immune response. I'm not going to go too much into the role of alemtuzumab, Campus that has and is available, however, not anymore commercially, only for specific indications. The goals of the induction treatment are already talked and mentioned, this predominantly to reduce the rate of acute rejections, but then also, and that is of relevance, to allow a delayed initiation of the maintenance immunosuppression, particularly calcineurin inhibitors, and the minimization, the reduction of the maintenance immunosuppression. Available agents are either monoclonal antibodies, the interleukin-2 receptor antibody basiliximab, or polyclonal antibodies, and here particularly the rapid antithymocyte globulin, thymoglobulin, that is available today. Now, it is important when starting out and thinking about the role of thymoglobulin to really look at its broad effects. What we consider the most important aspect of thymoglobulin is T-cell depletion. That is the main action of the agent. However, there are other aspects that are of relevance as well. There is an initiation of regulatory T cells, and that is important for the maintenance of a graft long term. There is some interaction and effectiveness in depleting both naive and activated primary B cells, plasma B cells, and other aspects of the humoral immune response that are important, and aspects of the innate immunity, the interference with dendritic cells, natural killer cells, that play a role, particularly in the early immune response. And then a broad anti-inflammatory aspect that is playing a role, again, potentially interfering with unspecific injury, ischemia reperfusion injury being one component. So when we look into the clinical data, there are different ways that we can summarize this. We can compare different induction treatments in the situation of deceased donor transplants. We can compare them by the immunological risk. We can compare them in deceased and in living donor transplants. So the comparison in deceased donor transplant comparing basiliximab versus thymoglobulin in regard to efficacy and safety. And here it is important to point out that overall the frequency of biopsy-proven acute rejections has been shown in the deceased donor population to be reduced. And at the same time, CMV infections and infections overall, interestingly, have been lower with the utilization of thymoglobulin, and there is some dose dependency here as well. Those are UNOS data, again, for deceased donor transplant, and they compare basiliximab versus thymoglobulin. And you see here that the death rate and the death rate with complications is higher with the utilization of basiliximab. Important, and what we see in transplantation occurring more frequently recently, and a challenging patient population, are patients that are sensitized. This here is a study in sensitized patients, in moderately sensitized patients that have donor-specific antibodies, but a negative cross-match. And what you see here overall is that the incidence of de novo DSAs is lower with the application of thymoglobulin compared to basiliximab. And likewise, we see in those sensitized patients a reduced rate of antibody-mediated rejections. I mentioned earlier that there is this broad range of effects on different immune compartments that we see with thymoglobulin. This here is a comparison of different targets, both with loci on HLA plus a comparison to specific receptors on T cells, and that is comparing thymoglobulin against the 𝐻𝐺 product. And what you see here is that the overall effectiveness and broad effect of thymoglobulin seems to be throughout significantly superior to that of the 𝐻𝐺. Now, one aspect that is always very important and that we are very mindful of as a consequence of the main effect, which is the lymphocyte depletion of thymoglobulin, is to see how other cell counts are doing. This here is a comparison of 𝐈𝐧𝐝 compared to thymoglobulin, showing different counts, platelets, reticulocytes, hemoglobin, and lymphocyte counts. They are overall comparable with a somewhat elevated rate for the counts of platelets and reticulocytes that was seen in this comparison of those two agents, 𝐼𝐧𝐝 and thymoglobulin, for thymoglobulin. In regard to the effectiveness, this is a study from India here that compared those two agents, thymoglobulin versus 𝐿, and looked into different outcomes. And they were different, particularly when we look at the rate of biopsy-proven acute rejections, which were lower for thymoglobulin compared to the 𝐿 application, here comparing doses for 6 milligrams for 𝐿 and 3 milligrams per kilogram for thymoglobulin. Now, one aspect that is important, and this is a study that we have done in our own center many years back, published in 2003, and that is the timing of the application of thymoglobulin. So is it sufficient, or does it make a difference if you apply thymoglobulin and have the dose of thymoglobulin already in the patient prior to reperfusing the organ, or is it sufficient if you have the dose applied after transplantation and after reperfusion? And that study showed that there was a significant advantage if thymoglobulin was applied and had been entirely applied into the patient prior to the reperfusion, with reduced rates of delayed graft function and a shorter length of stay for those patients who had the drug on board before the organ was reperfused. Now, coming to living donation, which I think is a centerpiece for the transplantation operation in this country, this is a study that was done by a group in Portland, Maine, published in 2017, and that study compared different dosages of thymoglobulin, 3 milligrams, 4.5, 6 milligrams, and looked into different outcomes in regard to sensitization and the rates, again, of biopsy-proven acute rejections. And you see overall that they have been quite comparable, the outcomes independent of the dosage, that the rejection-free survival, graft survival, patient survival throughout the different applications, different dosages, has been comparable. Now, the comparison between basiliximab and thymoglobulin has been done in different geographic areas. This here is again data based on patients in the US, comparing basiliximab versus thymoglobulin, both in patients who were in maintenance steroid treatment and off steroids, comparing here on the black bar the rejection rate after 1 year, and that is of particular relevance. If you compare those two, then you see a lower rejection rate in patients who were on steroid treatment that had received thymoglobulin, and the same was also true for patients that did not have a steroid treatment. Now, there have been two major studies in the US and in India looking into the thymoglobulin application, the Taylor registry in the US, the RISE registry in India, and they compared patients on a triple or double maintenance immunosuppression treated with thymoglobulin, and then looked at specific readouts, here particular biopsy-proven rejections graded. And you see here that both in those studies that the infection rates and the biopsy-proven acute rejection rates were low. The RISE study I already mentioned. This is living donor kidney transplants in India. Here again with a cumulative dose taken at 2.6 milligrams per kilogram. And what you see here is that the GFR by 6 and 12 months in a very reasonable amount with a very low rate of graft loss and a high probability of graft survival by 12 months. The rejection rate, likewise, as in the Taylor study, low, as was the rate of infections listed here. Now, there was another study that I want to mention here in low-risk haplotype-related living donor kidney transplants in India, also comparing thymoglobulin versus basiliximab. And again, you see that there was a lower rate of biopsy-proven acute rejections with the thymoglobulin application compared to the basiliximab application. And likewise, the acute rejection rate and the free survival in absence of an acute rejection was superior subsequent to the application of thymoglobulin in this low-risk population. Now, an aspect that has been close to my heart was to study particular aspects of the immune system in aging, both in regard to the aging of the recipient as well as in regard to the age of the donor. And that is an interesting combination as we see more acute rejections when we transplant older organs. Older organs seem to be more immunogenic, and at the same time we see a compromised immune response when we transplant older recipients. And therefore one can ask the reasonable question, what is the treatment of choice for an induction treatment in older recipients? And this is shown here in this clinical study that has been recently published in Transplantation. Patients that received thymoglobulin, older patients that received thymoglobulin. And here, with the application of thymoglobulin, it was possible to reduce the maintenance dosage of tacrolimus by month 3 significantly, and then overall throughout this observation period of 12 months. And with the reduced maintenance of tacrolimus, there was also a reduced rate of post-transplant diabetes in this older recipient population. So I think overall, in regard to the induction therapy, I think it's fair to say that thymoglobulin has broad immunosuppressive effects that are impacting all aspects and all compartments of the immune system, innate T cell and B cell humoral immunity. The side effects in regard to infections are overall acceptable. There are allergic responses that are seen that are very rare. Timing and dosage of the application is of relevance. I've shown you that it is of an advantage to have the entire thymoglobulin dose on board prior to the reperfusion of the organ. And you have also seen data that show that there is not necessarily an advantage of higher dosages above 3 milligram per kilogram in the application of thymoglobulin. So in summary, I think based on the most recent data that we have available, it seems fair to say that thymoglobulin presents overall with the particular dosages that I pointed out, the preferred induction treatment. With that, I want to thank you for your attention and happy to answer any question that you have.
Thank you, Professor. Please join us. So thank you, Professor Tullius, for giving us a comprehensive overview of the induction immunosuppression and what is the current role of anti-thymocyte globulin in living donor transplantation. So to just begin with, to ask you that, would you like to give the dose at one go, or you do it on the second day and the third day also when you use induction immunosuppression?
So there are also differences, but I would, the usual way that it is being applied is over several days. So you have the one dose that we would suggest to give prior to the reperfusion of the organ, and then have another 2 or 3 doses after that.
And do you monitor the lymphocyte counts to see if to give the next dose, or you would just give it?
I would monitor the lymphocyte count to see if you need to make dose adjustments.
Thank you. So, Iqbal, would you like to share your experience that what dosing did you use and how do you use induction?
Yeah, this thymoglobulin is a beautiful molecule in the sense that it can be structured and wavered, and according to your convenience, we can use. Actually, we in India, we all use low dose, and we end up using very low dose also, 1 mg per kg body weight. Usually, we use the 3 mg per kg body weight. And the low risk patient, we go for the L2 blockers. The high risk, we'll take the thymoglobulin, and medium risk, we have this other more Fresenius molecule which has come over to India, which is very useful in the mid-range. That's how we structurally use it. We go by the platelet count, and usually, do you look for the CD3 count categorically for every patient? Or
so the most sensitive, I would agree, we would look at the platelet count. We would monitor lymphocytes as well, but the clinically, I would think, most reliable parameter would be the platelet count.
That's what we go through. And see, looking at this, now we have conquered the T cell part, I think, by giving all these molecules. Now what we are encountering is the de novo antibody AMR and AMR. Do you foresee or do you recommend using B cell depleting agents as induction agents in the future? What do you say? What is your take on that?
So that depends. It depends on what kind of scenario you are operating. If you have a highly sensitized patient, very highly sensitized patient, ABO incompatible transplant, then you may consider that the induction treatment with rituximab. In general, I don't think that would be reasonable to use rituximab, and it would be, I think, the preferred induction treatment would be thymoglobulin.
I do agree that in our country, sometimes people do use a low dose Ritux along with the ATG, but I think it increases the risk of infection significantly when you're completely blocking both the B and the T cells. Ritesh, would you like to share some?
Professor Tullius, you quoted a study where low-dose thymo is used in haplo-matched individuals. I was part of that study, and how it all began was, about a decade ago, we all were convinced that, we still are, that thymo is the induction of choice in high-risk individuals. And then the KDIGO guidelines recommended IL-2 receptor antagonist as the drug of choice for induction in low to moderate risk. However, these were based on studies which were using cyclosporin as their maintenance immunosuppression. So when we compared the data of basiliximab in cyclosporin-based immunosuppression, we were preventing 1 rejection in 8 patients. Whereas when we were using this in tacrolimus-based immunosuppression, we needed to treat 80 patients to save 1 rejection. So that's when we picked up the idea to use low-dose thymoglobulin. Now, low dose was 3 milligram per kg, and use it even for low-risk patients. And that's what it has shown, that even in low-risk haplo-matched individuals, when you're using thymoglobulin, you have a rejection of 5%. Whereas basiliximab, we had a rejection of 18%. and no induction, we had a rejection of 17%. So once you have a good graft function initially, everything becomes easier to manage. You can minimize your mycophenolate, go down on tacrolimus, and that's the beauty of the drug, that now we don't use basiliximab even in the low-risk categories. And regarding rituximab, we probably will be using it in high-risk HLA incompatible transplants for desensitization, but not as a regular protocol.
So the KDIGO guidelines go back more than 10 years, and there has not been an update since then. And the data that I presented were more recent, and I think the approach has changed, the clinical practice has changed, and that has not been implemented in the KDIGO guidelines yet.
I think I agree there's a time for the KDIGO to revise its guideline. They have been telling so, but not yet coming out with it. If there are any questions on the floor, Dr.
So do we give up basiliximab altogether, even in case of low risk transplant patients?
So the question is, would one
Should we give up using basiliximab even
in low risk?
Low risk, or should we give a lower dose of ATG in
I think
low risk?
to me, based on the more recent literature, it seems to be preferable to use a low-dose thymoglobulin treatment.
Thank you, Professor. We've just run out of time, and I think we need to close the session now.